But welcome everybody who's managed to come in. This is great. As you know, this is our last session, this introduction to orthoptics. And I'll now hand you over to Rowena for session 7, which is the third and fourth nerve palsies.
Good. Hello, everybody. Today will be the last in the series, and I'm going to talk about the nerve palsies which cause patients to have double vision, because these are the patients I think that will be coming to your clinics for your help. So to recap what we talked about last time was the defects that happen when the nerve supply to the muscle isn't working properly. And there is a reaction to that defect which happens in a pattern, and those patterns have been called laws or reasons for the patterns. So to understand the pattern of change, we need to make sure that we have understood Herring's law of equal innervation. And this law states that when a nervous impulse is sent to an ocular muscle to contract, an equal impulse is sent to the contralateral synergist. And these are long terms which come from a Latin language, but they are useful because you know immediately which muscle it's referring to. Contralateral means the other eye, and the synergist is the muscle that works together. So the example I've given here is that when you look to the left, when there is a left gaze from the left eye, the lateral rectus has been sent a message to contract, and at the same time, due to Herring's law, the message also goes to the right medial rectus. So that is the law of equal innervation. And just as everywhere in the body, like your legs and your arms, when the muscle contracts to make the bone move in your arm, the opposite muscle has to relax. So Sherrington's law is the relaxing part, the reciprocal innervation. So when one muscle receives a nervous impulse to contract, there's an equal impulse for its antagonist to relax. So in the above example, the left eye moving to the left, you would use the left lateral rectus muscle, and the opposing antagonist, the medial rectus, would have to switch off. It would have to relax. Otherwise, the eye would not be able to move. And we talked about testing the eyes of a patient in directions of gaze to find out which muscle or muscles are not working properly. So when we ask the patient to look up, we're testing the action of the superior recti. When we ask the patient to look up to the right, we're testing in the right eye the superior rectus action, but in the left eye, the inferior oblique starts to be the main muscle that pulls the eye up in that position. So in this way, we can find out where the defect is, and therefore whether it's a nerve palsy of the third, fourth, or sixth cranial nerves. I left you with a puzzle at the end of the last session, which was to write down the sequence. And I realized that right and left can sometimes sound the same. So obviously we're going to have to write it very clearly. So with the example, what would the muscle sequence be for a right lateral rectus palsy? We had the right lateral rectus is the primary defect. The overaction in the other eye of the medial rectus is due to Herring's law. And then if that doesn't get better, if it stays and it progresses, we get stage 3 and 4 So in stage 3, we have an overaction of the medial rectus in the same eye. And that's due to the fact that when the muscle is being overacted in order to make it work, the other muscle is also going to be unopposed. And the secondary inhibitional palsy of the left lateral rectus is the last stage in the sequence. So I'm going to be talking about these 4 stages of sequence with other nerve palsies today. Starting off with the third nerve, there's got a lot of perhaps new terms. So I'm just going to list the terminology that we use for the third nerve palsy. So in a third nerve palsy, the nerve innervates the levator. And so you will get a ptosis happening if the third nerve is completely out of action. So you need to remember the term ptosis for a drooping eyelid. The eyelid, the upper eyelid, is worked mainly by the levator to elevate the eyelid. The third nerve also sends impulses to the pupil, to the sphincter pupillae, to make the pupil smaller, so that if there's a third nerve palsy, the patient gets a fixed dilated pupil. The third nerve innervates 4 cranial, 4 ocular muscles. So sometimes it can be affected completely, and sometimes only 1 or 2 of the muscles could be affected. And the other terminology is that sometimes the palsy is complete, so there's absolutely no movement of the eye. And in other cases, perhaps the embolism or the ischemic attack is only partially affecting the nerve. So you can have a total paralysis or you can have a partial paresis. The third nerve divides into an upper and lower division. So again, you can get muscle palsies in just the superior rectus and the levator because it's an upper division lesion, or you can get just a lower division being affected, which would be the medial rectus, inferior oblique, and inferior rectus. If there's a complete third nerve palsy, it gives you an exotropia and a hypotropia. And the way that we remember that, or a trick to remember, is that the eye becomes down and out. So the eye that's affected points downwards and points outwards. So there's an exotropia and a hypotropia. And this can be caused at birth. So when the child is developing in the last gestational weeks, it could occur, or it can be acquired, and it can be acquired in children as well as in adults. So I'm hoping that this terminology is in use at the moment, but if not, it's a point that you're going to have to become familiar with them. So the third nerve anatomy is that there's a third nerve nucleus in the midbrain, and there are different sections in the third nerve nucleus on the right side and also on the left side of the brain. And each section, each subnucleus, has a job of innervating one of the muscles. So we've got them listed here, 1, 2, 3, 4, 5, 6. So we've got number 1, innervating the inferior rectus, number 2, the inferior oblique, number 3, the medial rectus, number 4, the superior rectus, and number 5, the levator, which goes to the lid, and number 6, the pupil reflex, which goes here to the sphincter pupillae. So the nerve divides into 2 sections. There's an upper section and a lower section. And as I said, you can get different variations of damage. You can get a variation where it's only the upper division affected, And you can get a variation where it's only the lower division which is affected. The causes of the third nerve palsy, it can be due to trauma, as in a bang on the head or a road traffic accident. It can be due to vascular changes, so that the patient may have stroke, or it may have an embolism. It could be due to certain types of tumour, things in the midbrain, and it can also be tumours in other parts of the body, so that they then travel around the body and it affects the eye as well. So it could be secondary to lung cancer, for example. You can also have problems of inflammation. So you could have inflammation due to bacterial problems, sarcoidosis, and we have certain syndromes where there's inflammation of more than one nerve and more than one nucleus. The most common causes in adults is an aneurysm. And that's because as you get older, your blood vessels are going to be susceptible to damage. So there is often a pupil involvement. If there is an aneurysm, the pupil will be dilated. One of the diagnostic signs is that in diabetes, often the pupil is not affected. So it can be used as a differential diagnosis sign between a blood vessel problem which is due to blood vessel disease as opposed to a blood vessel problem due to diabetes. It's quite a long nerve as it comes through the midbrain, so any damage to the head or any trauma could cause a third nerve palsy. And as I said, you can have tumours within the midbrain that would also give you the same signs. So it can be present in babies. You can have it as a child, or it can be acquired. It can be acquired in the very young if they have a very high temperature, or it can be acquired in any adolescent right the way through life. It can involve all of the muscles, or it can just involve some of them. As we said, it could be an upper division or lower division. The pupil might be dilated, or it could be normally acting if it's due to diabetes. And it can be a total paralysis or a partial paresis. And we looked at the ways of recording eye movements, and we agreed that it would be useful to use the standard scale, which goes from 0 to 4. So if there's complete absence of action, we would give it a grade of -4. And if it's only a mild underaction, we would give it a grade of -1. And we'll give some examples of that today. So here is a picture of a patient who has come to the clinic. It's a male patient who is 70 years old. And he's come to the clinic with his eyes looking as if he's very uncomfortable, but actually he's relaxed with his left lid lowered. He doesn't have any double vision because he has the left lid covering his left eye. So he doesn't get diplopia. He doesn't get double vision. He's just seeing singly out of his right eye. However, when we lift up the lid, we can see that his left eye is turning outwards. So I said that we remember this characteristic from this muscle palsy, that the eye, when it has been affected, will be down and out. So in this case, when we raised up his left lid, we can see he has a left exotropia of about 35 prism diopters, and he has a hypotropia of about 10 prism diopters. And in his case, he doesn't have a dilated pupil. The pupil has been spared, and so the most likely etiology is diabetes. So looking at his 9 positions of gaze, I want you to look in the primary position to start with. So if you look at the same picture as on the previous slide, he's looking at us with the right eye, and I have lifted his lid with my finger so that we can see the position of his eye underneath the lid. So in each position of gaze, I'm lifting the lid myself with my finger so that we can see the eye. So in the primary position, we have an exotropia in the left eye, the eye is out, and a hypotropia. When we look up, we're testing the muscles of both eyes. We're testing the superior rectus action. And as you can see, his left eye is not going up. So he has defective elevation. And to test the superior rectus in its primary gaze position, we make the eyes move outwards by 23 degrees. And now we're looking at the main action of the superior rectus in the left eye. And we can see that it is not moving upwards. And it's not moving upwards above the midline, but it moved up a little bit from its hypertropic squint position. So I've graded it as -3. It's not a measurement, it's just a score. So I'm just saying that looks to me like it's only got 25% of action, so it's -3. When we look to the left eye is abducting fully. But when we look down, when we look straight down and when we look down to his left, the inferior rectus of this left eye is not working fully. So this eye has gone down, this one is stuck. So he has defective depression in his left eye. The depression is better than it was in trying to look up, so I've only scored it as -2. So I think it's still got 50% of its action. When we get the patient to look to the right, we're now testing his medial rectus in the left eye, along with the lateral rectus in the right eye. And as you can see, he can't adduct. So in the primary position, the eye is turned out. And even when we try to make him look as far as he can over to the right, this left eye has not come beyond the midline, beyond straight ahead. So we can call this -4 or even -5. So the last muscle, which is part of the third nerve group, is the inferior oblique. And the inferior oblique elevates the eye, and it elevates it maximally when the eye is adducted. So we look for the action of the inferior oblique when the eye is looking inwards and upwards. And here again, you can see it can't go up. So we've got the left inferior oblique -3. Remember that the medial rectus is the main muscle to adduct the eye, so it can't adduct the eye in the primary position and also in looking up. So when we try to adduct the eye, it's limited in elevation, in adduction, and also in depression. So how we can draw that out in a diagram is with these hashed lines. So we've got the left eye represented here in the chart, and this is the representation of the right eye. And we've got the maximum area of action of our 6 extraocular muscles. So we transfer those marks that we put onto the 9 positions of gaze, we transfer them onto a diagram, and the eye is unable to move, so we make a hashed line to show that it is completely limited. So even when we cover the right eye, the left eye cannot move up, it cannot move in, and it cannot move down. It's not the same defect in each position, so there's a greater amount of defect. So there's a -4 in adduction, but his down gaze is a little better. So we only gave it -2. So that is a diagrammatic way that you can summarize without having to write it out in words. So it's a good, quick way of representing your results. So that particular gentleman had a history of a sudden onset of a leftosis, and he came to the doctor, he came to the eye clinic within 4 days. He came to casualty, but he didn't have any double vision because the left lid was completely covering his left eye, so he didn't have any two eyes working in different directions because the lid was covering the image from the left eye. So it wasn't a symptom. He didn't know why it had happened, but he told us that he has been a non-insulin dependent diabetic for the last 10 years. So he has had no previous eye surgery, he hasn't had any cataract surgery, and he didn't feel that his vision was impaired, and he didn't need an eye patch because he did not have double vision. So we just reassured him that in most cases this is going to go away by itself, and indeed in nearly 80% of patients with diabetes, this muscle palsy will go away within 3 months. Some of them will still improve after 6 months, and a few after even longer, 6 to 9 months. So here he is now. The lid is better, and his eye movements are better when we tested him, but you can still see he has maybe a slight asymmetry of his pupil and maybe a little bit of exotropia. But gradually it will go back to normal. So here is a case of a congenital type of third nerve palsy. So this child was born with this problem, and in children they quickly ignore double vision. So they don't complain about their eyes. It's the parents who notice the problem, and the parents come and say, my child isn't looking properly, please do something about it. So in the primary position, we can see that the eye is down and out, the right eye is down and out, but this time the ptosis is not complete. So there is only a partial right ptosis. So there's a partial palsy of the levator muscle. But you can see when they are asked to look up, the left eye moves up fully, the right eye doesn't move up beyond the center. So again, I've scored this as -4. When they try to look down, it looks as if the eye is rotating down quite well. So this time I've given it -2. But when they try to look to the left, the right eye cannot adduct, and it doesn't adduct beyond straight ahead, so I've given it -4. When they look to their right, everything looks fine, because in their left eye, they've got the lateral rectus working properly, so they can look to the right with their lateral rectus in their right eye, and they can look to the medial side with their normal eye. So everything looks symmetrical looking to the right. Remember that looking upwards is testing both the superior rectus and the inferior oblique. So although I haven't got pictures of the diagonal positions, when they look up to the right, it will be -4. And also when they look up to the left, they also cannot elevate with the inferior oblique not working. So the third nerve innervates the superior rectus and the inferior oblique. I said that sometimes the third nerve palsy can be incomplete. So I said that we can have a superior division where you only have the superior rectus affected and the levator. You can have an inferior division where it is affecting the medial rectus, inferior oblique, the sphincter pupillae for the pupil, and the ciliary muscle for the accommodation. Or you can have single muscle palsies. So we may have just the superior rectus, just the medial rectus, just the inferior rectus, and just the inferior oblique. So in this patient, this child at the age of 11 suddenly got a partial ptosis with dilated pupil, but she doesn't have an exotropia, so the medial rectus is not so much affected, and she doesn't have a hypotropia. So it's only affected the levator and the pupil and the medial rectus. So it's not all of the muscles being affected at the same time. So what I'm going to do is I'm going to summarize what would happen if you had a patient who had just one of the muscles affected at any one time. So we've said that the third nerve innervates 4 of the extraocular muscles. So I'm going to go through those 4 extraocular muscle scenarios. So the action, if you remember, of the superior rectus, the main action is elevation, and it gets stronger when the eye is abducted. The secondary actions are very slight. So it has a slight adduction action and it has a slight encyclorotation action. Now, what patients will try to do is they will try to move their head in order to avoid the double vision. So we call this an abnormal head posture. So the patient will normally find out for themselves that if they move their head to the side, or if they put their chin up or down, or if they tilt their head, then the diplopia images come into one. It joins up the images. So if a patient has a superior rectus palsy, they may learn almost immediately that if they put their chin up and put their eyes away from the upgaze problem, they don't have double vision. And they will turn their head towards the muscle that's affected and they will tilt it in order to join up vertical diplopia. So here is a patient with a superior rectus palsy. So in this picture, the patient has their chin up. This is not just shyness, or this is just not a habit. You want to ask the patients to stand up straight in the clinic and ask them to make everything single and take a photo, hopefully, of their face. And here you can see that there is more ear showing on the left side and less ear on the right side. So the patient is turning their head to their right side and they've put their chin up. And that's to avoid the right superior rectus palsy. When we ask the patient to put their head straight, or you may have to actually put your hand on their head in order to encourage them to put their head straight, then they will probably say, oh, I don't like it like this because now I can see double. I can see double and the images are one above the other. So it's very uncomfortable. And you can observe from your own clinical observation that there's a partial ptosis. And when you do the cover test, you will probably find a right hypotropia. And by putting their chin up and turning their head, they're avoiding the area which gives them double vision. So when they have double vision, if the images are one above the other, it can be very uncomfortable, very disorientating. And in fact, they may actually want to have their hand over the eye that's giving them a double, or they will be very happy for you to give them an eye patch. So to transfer the weakness of the superior rectus onto our diagram, we've got the schematic diagram here, and I've put on the first, second, third, and fourth stages of the muscle sequence so that you can apply the rules that we looked at with the lateral rectus. We want to now apply them to the vertical recti. So if we have a superior rectus palsy in the right eye, and we've graded it with -3, that's our primary underaction, our primary palsy underaction. So we said, due to Herring's law, that at the same time you get an equal innervation to the synergist, or the muscle that works together in the other eye. And sometimes we call these yoke muscles because they're yoked together. So this is the first stage of the sequence, and this is the second stage of the sequence. So then in the same eye, you will get an overaction of the antagonist because this is pulling against a muscle which is not working. So it's seeming to overact because there's nothing pulling in the opposite direction. So it seems as though it's pulling too strong. And then the fourth stage, eventually, it may happen after a few weeks or a few months, is the secondary inhibitional palsy. And this is because of the imbalance between the overaction and the underactions that are happening in the pair. So this one starts to underact. So if you can get used to this sequence, you can look for the pattern when you're doing the eye movements. So if you see the underaction of the primary, then you can look for the other two muscles to see what's happened. And you can map out how long this palsy has been present. The next muscle that I want to look at is the inferior oblique. So the inferior oblique muscle, although it's attached inferiorly on the globe, because it's attached behind the equator, it actually elevates the eye. So the main action is torsion, but it becomes quite a significant elevator when the eye is adducted. So in this case, the child doesn't have a ptosis because the lids look the same level, but they have put their chin up and they've turned their head in order to avoid the area where the inferior oblique is not working. So the cover test with the head posture will be a foria, a latent squint with single vision, and without the head posture, there will be a manifest squint with double vision. So here are her 9 positions of gaze. This is the same picture in the primary position. So there's a no manifest squint in the primary position. But when she tries to look up to her left, we can see that her right eye doesn't elevate, and it doesn't elevate at all. It hasn't gone beyond the center. So we call this -4. So this is your primary muscle underaction. And the secondary overaction of the synergist is usually by an equal amount. So this one goes high, this one isn't moving at all. So we scored this as -4 and +4. So this is the primary underaction, and this is the secondary overaction of the synergist in the other eye, the contralateral synergist, which is the left superior rectus. Now we look for stage 3 and 4. So stages 3 and 4 would be in down gaze, because you would get an overaction of the ipsilateral antagonist because there's nothing pulling against it, and then you'd get the secondary inhibitional palsy of the contralateral antagonist, and it doesn't look very obvious from these pictures. So we can see the primary palsy and we can see the immediate overaction of the synergist, but we can't see the stages very clearly in stage 3 and 4. So what we would write down on the chart for that lady is that she's got -4 under action of the inferior oblique of the right eye, and that's our primary defect. The secondary part is the overaction of the superior rectus in the left eye, but very little overaction of the ipsilateral antagonist and very little underaction of the contralateral antagonist. So we've got stage 1 and 2, but very little stage 3 and 4. And so this is unique to each patient. Every patient will be different. The fourth muscle, which is innervated by the third nerve, is the inferior rectus. If the patient has an inferior rectus palsy, the problem is when they look down. So you can see this patient has got their chin down in order to avoid looking in that position where there is a defect. So remembering the inferior rectus is our main strong depressing muscle, and it works more effectively when the eye is abducted by 23 degrees. And the secondary actions are very minor. So it has a slight adduction effect and a very slight rotatory cyclo effect. So the chin is down because the patient doesn't want to look down where it's double vision. And they're turning it to the side. You can see all of his left ear, and you can't see any of his right ear because his head is turned. And this is to give him single vision. So the cover test with the abnormal head posture would be that there's a phoria, a latent squint. And this is a vertical phoria because the muscle is a vertical acting muscle. Without his head posture, he would have a manifest squint, a tropia, right hypertropia, with exotropia, and he would have diplopia. So here are his 9 positions of gaze. In the primary position without the head posture, he's got a right hypertropia. So the right eye is higher than the left. Looking over to his right, he has a problem, maximum, looking down to his right. So the right eye is not moving down, and we've scored this as -4. The eye doesn't even come to the straight ahead position, doesn't come to the midline. So this is our primary muscle palsy, and the overaction has also happened in upgaze. So we have our primary muscle underaction in the right inferior rectus. We have overaction of the synergist in the left eye, which is the superior oblique. And then the muscle sequence has gone to stage 3 and 4 because we can now see also that the right eye is higher than the left when looking up here, up to the right. So we've got stage 3, and lastly, the inhibitional palsy would be stage 4 here. So of note, looking in the opposite direction, everything is normal. He does not have double vision looking up to his left. He does not have double vision looking down to his left. And he does not have double vision looking straight to his left. So he turns his head to avoid the double vision which is happening in right side. So the ocular motility of the right inferior rectus palsy with the right eye defective depression on right down gaze. And how we transfer that into the eye diagram is that we put by the inferior rectus of the right eye -4. That's the first primary underaction. The secondary overaction of the contralateral synergist is the overaction of the left superior oblique. Stage 3 is the overaction in the same eye of the antagonist. So that is the superior rectus of the right eye. And then the 4th stage is the secondary inhibitional palsy in the left eye of the left inferior oblique. So I hope that you can start to see that there are patterns, because you can see the unison of the right and the left eye synergists, and the pattern is always minus, plus, plus, minus. Medial rectus palsy is difficult for me to illustrate for you because it is so rare. So I don't have any examples. In all my years of practicing as an orthoptist, I have never seen a pure medial rectus palsy. I have seen lower division third nerve palsies, but I've never seen a medial rectus palsy which is caused by a lesion in the third nerve. But in theory, you would have a face turn and you would have an exophoria in the primary position with the head posture, and an exotropia without the head posture. So hopefully you will never see one either, because they're so rare. This is how the pattern would look on the chart. So just for completeness, we've given an example. You would have a primary right medial rectus under action. The second sequence would be overaction of the contralateral synergist, which is the lateral rectus in the left eye. The third part would be the overaction of the ipsilateral antagonist, which is the lateral rectus in the right eye. And the fourth part would be the secondary inhibitional palsy, which would be the medial rectus in the left eye. So that really concludes all of the muscles that are innervated by the third cranial nerve. And so I want to now go on to the fourth cranial nerve. So we've had the sixth cranial nerve giving you a lateral rectus palsy, the third cranial nerve giving you 4 muscles that are affected. So that's 5. So we've got the sixth one left over. So the sixth cranial muscle is the superior oblique. And the superior oblique, remember, although it's on the top of the eye, and that's why it's called superior, it actually depresses the eye because it's attached behind the center of rotation of the eye. So things that can affect the nerve comes out from the dorsal part of the midbrain, the back of the midbrain. And because of that, the roots go from the nerve nuclei in the midbrain, they go out the back of the head, and then they curve around the midbrain. So because they're on the dorsal root, patients who have head injuries from whiplash are particularly susceptible to fourth nerve palsies. So by that I mean if you're in a car and you have a head-on collision, the car stops and your head gets thrust back. Now, even if you have a seatbelt on, it could be that you're in a car that doesn't have a headrest and it doesn't stop you fast enough, and you get this thrusting back and then forward again. And so all the contents of the brain are shifted forward and back, and it can pinch these nerves as they come out of the midbrain and come towards the superior oblique. So that's the most common. The incidence reduced hugely when we had seatbelt regulations, but it still does happen from time to time. So the nerves come from the back part of the brain towards the eye, and they go through the superior orbital fissure and the cavernous sinus, and they're close by to other cranial nerves at those points. So sometimes you can get a fourth nerve palsy and a third, or you can get a fourth and a sixth, or a fourth and a fifth. So all of those nerves are close by to one another as they come forward towards the eye. and it inserts into the superior oblique muscle. And then remember, the muscle comes forward through a trochlea, and then it inserts behind the center of rotation of the eye. So when this tendon is pulled tight by the muscle contracting, the eye goes down. So remember, it's on the top of the eye, but it pulls the eye down, and it also has the main action of in-cyclotorsion. So as it's the main in-cyclotortor, if there's a fourth nerve palsy, the patients often complain that images look tilted because the whole world has become tilted the wrong way. So it is one of the tricky ones because although it's called superior oblique and it's on the top of the eye, we test its action when we make the eyes look down into adduction. And remember, that's because although the main action is torsional, it also has a substantial depressing action. And so we tend to always test its depressing action in down gaze, in adduction, when the eye is turned in. So the action is mostly in torsion, but when the eye starts to be rotated in, the depression becomes more significant. And that's why we test the action of the superior oblique when the eye is down and turned in. And that's where the patient will say that their symptoms are worse. So they might say, I get double vision when I look down, when I'm going downstairs, or when I look down when I'm reading. So that the symptoms are worse when looking down and with the eyes turned inwards. So the head posture for the patient will be that they will try to put their chin down to avoid the double vision. And they also tilt their head to the side and they turn it slightly. So again, you can see the ear on this patient. You can see the right ear, but you can't see his ear on the other side. With his head straight, so now we've asked him to put his head straight, you can see his left eye is looking at you and his right eye is pointing up. So he has a right hypertropia without the head posture. And he will notice vertical diplopia, and he will also say, and the vertical image, the false image is also tilted. So it's rotated, and that's because the main action of the superior oblique is to in-cyclorotate the eye. So the main action we're testing is the depressing action. So when we ask the patient to look into the corners, we're testing the superior obliques when the eye is adducted. So here we have a patient in the primary position. When he looks up, everything looks fine. When he looks down, everything looks fine. He looks to the right, everything is fine. And then when he looks to the left, when he looks down to the left, he says, I've got double vision. One image is above the other and the lower one is tilted. So here he has a -2 under action of his right superior oblique with an overaction of the synergist in the other eye, the contralateral synergist, which is the left inferior rectus. And he also has some up gaze incompetence as well. So we've got stage 3 and 4. So stage 3 is the overaction of the ipsilateral antagonist, which is the inferior oblique of the right eye. And the last, stage 4, is the secondary inhibitional palsy of the left superior rectus. Transferring that onto our chart, we've got the primary underaction of the right superior oblique. That's our first stage in the sequence. We've got the overaction of the contralateral inferior rectus. That's our contralateral synergist. Stage 3, we've got the overaction of the ipsilateral antagonist, the inferior oblique. And stage 4, we've got underaction of the superior rectus in the contralateral eye, which is the contralateral antagonist. So that's all I wanted to do today. I'm going to show you a video of the superior oblique palsy eye movements. And I thought you might like to do some homework. So we wrote down last week the lateral rectus muscle sequence, but you might like to have a go at doing the left superior rectus and the left superior oblique. So that would be a homework exercise, or you can discuss it with your friends and colleagues. So I'm going to show this video and I'll just let it run through without comment, and then I'll talk you through it. Okay, so I'm going to run it through again and just give you a commentary of what to look out for. So first of all, the first few frames are the cover test. And I'm using a translucent occluder so that you can see what happens behind the eye. Normally we use an opaque occluder to cover the eye so we know the patient's really following the instructions, but I've just used something that you can see through so that it's easier for you to see what's happening. So we cover the left eye, the right eye moves down and out. So there is a right hypertropia, the left eye is straight. So there's a right hypertropia and esotropia. When we look to the left side, the right hypertropia has increased. So the right eye is starting to drift up. When we look up to the left, the right hypertropia is the same as in the horizontal position. When we look down to the left, the right hypertropia has got bigger. So there is an underaction of the right superior oblique, and I would score that as -3. When he looks to his right, there is no vertical. The vertical has gone away because the muscles are in balance. So in right gaze, there is no problem. He has a tiny exophoria. No height. No vertical squint. And when he looks down to his right, again, there's no vertical incompetence. So the problem is in his left gaze. Okay, so I'm just going to run that through one more time. The cover test shows a right esotropia with hypertropia, about 10 diopters. Directly into left gaze, the right hypertropia increases to about 20 diopters. When he looks up to his left, the right hypertropia is not increased, it's reduced. It might now about 10 diopters again. But when he looks down, the right hypertropia is much bigger. So he has -4 underaction of his right superior oblique. Looking to the right, there is no vertical. Just has esophoria. Exophoria looking up. Good. Okay, and that's all for today. If anybody would like to put anything in the chat, I'm just going to keep the chat open for a couple of minutes. I think you probably will want to think about the questions because it will take a little bit of thought to work out the muscle sequences. But that's something that you can discuss yourselves. And then we hopefully will be with you in a few weeks' time when we can go over these lectures again with you and you can discuss them with us. Or if you have any questions in the meantime, obviously you can put them in our WhatsApp group. There's an International Orthoptic Association and there's also an International Pediatric Ophthalmology Association. And the International Pediatric Ophthalmology Association puts on workshops and webinars. And it's free for anyone who wants to register. So I have a link which I can put into the WhatsApp group. So if any of you would like to register, you can register online. There's no cost. And then you will hopefully be in touch with the organisation personally, and they can send you notifications of any further webinars that go on. The one that's going to happen, as I say, it's paediatric ophthalmology, so it's going to be an emphasis on testing children, which is something that we haven't done, but it might be useful for you to just watch and see what methods they suggest.
Yes, and that date is April 26th, 3:30 in the afternoon in London, so it'll be 4:30 in Malawi, which is not too.
That's not too bad, actually.
No. We'll put that link into the WhatsApp group so you can all see it. And we look forward to our visit coming up very soon.